let's move forward. Title today is Advanced Osteoarthritis of the Knee and TKR Options. We have very eminent faculty from local and abroad, and I will introduce them to you in due course of time. But before we begin anything, let's begin with recitation from Holy Quran. Over to you.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم.
وأيوب إذ نادى ربه أني مسني الضر وأنت أرحم الراحمين فاستجبنا له فكشفنا ما به من ضر وآتيناه أهله ومثلهم معهم رحمة من عندنا وذكرى للعابدين وإسماعيل وإدريس وذا الكفل كل من الصابرين وأدخلناهم في رحمتنا إنهم من الصالحين وذا النون إذ ذهب مغاضبا فظن أن لن نقدر عليه فنادى في الظلمات أن لا إله إلا أنت سبحانك إني كنت من الظالمين فاستجبنا له ونجيناه من الغم وكذلك ننجي المؤمنين وزكريا إذ نادى ربه رب لا تذرني فردا وأنت خير الوارثين فاستجبنا له ووهبنا له يحيى وأصلحنا له زوجه إنهم كانوا يسارعون في الخيرات ويدعوننا رغبا ورهبا وكانوا لنا خاشعين.
Jazakallah, thank you. Allahumma salli ala Sayyidina Maulana Muhammadin wa alihi barik wa sallim alayh. So we will begin the proceedings of this 26th webinar. And our first speaker is Dr. Mansoor Ali Khan, who is a fellow alumnus from our program in orthopedic residency. We did it together. He was a year senior to me. And he graduated from Dow Medical College and then did his FCPS in orthopedics and is currently working at the Indus Hospital and South City Hospital, Karachi. Currently, he is a very eminent surgeon in Karachi and does joint replacements, arthroscopy, as well as he's the pioneering person of the club foot program, the Ponsati treatment program in Karachi and Pakistan. Actually, very pioneering work in that field also. Today, we engaged him to give us a talk on posterior stabilized knee. That will be our first topic, and we will move down in that order to PCL retaining knee, and then mobile bearing knee, and then medial pivot knee. And then Khalid will take us through very difficult cases of his more than 30 years of experience. So over to you, Dr. Mansoor, please.
Assalamualaikum. I'm very honored to be here, a very distinguished faculty. Thank you, Masood, for inviting me. And I'll try to keep this informative without being too complex. I hope it's okay for everybody. My name is Mansoor Ali Khan. I'm at Indus Health Network, as Masood has described. And just mentioned, there are no disclosures in relation to this presentation. And if inadvertently I do mention any specific TKR implant, it does not imply endorsement of that implant. This is not progressing for some reason. This is where I work. This hospital started in 2007, and this hospital started with a building which was supposed to have 150 beds. We started with 25. We are now at 350 beds, and this is our main expansion, which will take us to 1100 beds, hopefully in the next 4 years. And Indus Hospital is part of the Indus Health Network, 14 hospitals across Pakistan, and we now have a boat clinic, which is designed to serve the riverine areas of the River Indus where there is no healthcare and no access by roads. So we try to keep ourselves busy. Okay, knee biomechanics. Now, knee biomechanics is a textbook, or actually several textbooks in its own right. So I'll just leave everybody with these few diagrams as a refresher to remind everybody what a huge variety of movements takes place at the femoral and tibial joint. And all of these are very, very hard to reproduce in a knee replacement arthroplasty because this is God made, that is man made. And we are still actually understanding the full biomechanics of the knee. So different philosophies have evolved over a period of time to try to match this as close as possible. And I think we are still quite a distance away, as we'll just find out in a little while. Two basically broad approaches developed over time in the evolution of a TKR. One is the anatomical approach, which is focused basically on preserving both, as if initially the ACL was also preserved, or one of the cruciates. The second is the functional approach, in which the designers and the surgeons believe that excision of the cruciate triggers the boat clinic. Okay, knee biomechanics. As I was talking about, it's a whole textbook in its own right, and it's impossible to explain in a 20-minute presentation. But it's just that, as I was saying, that it's impossible for man to mimic the natural movements of a God-made knee, and we are trying as best as we can. And with time, two different schools of thought have evolved. One is the anatomical approach, which is focused on preserving either both, as initially even the ACL was preserved, or one of the cruciates. The second school of thought favored by many designers and surgeons is the functional approach, which is based on the excision of the cruciate ligaments, both of them, and focus on biomechanics in the shape of the implants to give the stability. Now, these are the problems which have to be solved in any kind of knee design. It's kinematics, the range of motion, the wear of the implant, the loosening of the implant, proprioception, gait and stair climbing ability, correction of deformity, bone loss, which is a very significant issue in our part of the world at least, the stability of the implant in the long term, as well as patella and the joint line height. Now, the Australian Arthroplasty Registry, I found this very simple, that they have basically categorized into these types. The 5 major categories for stability are now minimally stabilized. From this, they're assuming that they're cruciate retaining. The medial pivot design, which another August speaker is going to be talking about, so I will not touch on that. Posterior stabilized, which is my topic. Fully stabilized and hinge prosthesis, which are greater and greater levels of constraint. Now, the PCL is considered to be a very important pivot point on the knee, very important for stability in 30 to 90 degrees of flexion. And it is felt that if it is sacrificed, a lot of problems with the knee reconstruction can happen. Now, the kinematics, which have been favored by the people who favor preservation of the posterior cruciate, it preserves femoral rollback, it increases the range of motion and preserve anterior tibiofemoral contact. The posterior stabilized group believe that by excising the PCL, it is dictated by conforming geometry of the tibiofemoral articulation, and the post and cam can do all the work the PCL had been doing. Now, the thought process behind trying to save the PCL is that it is needed for stability in the coronal and sagittal planes. It does help in the femoral rollback. It does allow increased flexion. It helps produce a more efficient quads mechanism, which helps in stair climbing. Proprioception is definitely something which can be thought to be correct because the PCL does contain nerve endings. It is a glide between femoral and tibial components. It helps decrease wear, but it requires soft tissue balancing to be very carefully done. The sacrifice PCL group feel that it's an easier surgical technique if the PCL is excised and gives a better exposure, and an improved ability to correct deformity and restore alignment. However, a congruent prosthesis is then needed, which then leads to less stress on the poly and relies on the principle of balanced flexion and extension gap. Now, this is just a simple picture of a PCL retaining design. And the design which is important for intact PCL implants is minimally constrained prosthesis that depends on intact PCL to provide stability in the flexion mode. The indications would be arthritis with minimal bone loss, minimal soft tissue laxity, and an intact PCL, varus deformity less than 10 degrees, and a valgus deformity less than 15 degrees. Now, all of us who do arthroplasty in Pakistan, at least my experience at Indus Hospital is that we get very, very few patients who fit in this category. Most of them have extensive bone loss, significant varus of valgus, and marked flexion contractures. So that is a totally different category. I have seen surgeries done outside Pakistan. I had the opportunity to spend time with a friend in Dallas, and the people who are coming there for knee replacements, we don't even see them in outpatient clinics. Advantages are thought to be it avoids the cam post impingement and the dislocation which can occur in some PS knees, and more closely resembles normal knee kinematics, which is controversial point. I think there's a very important point that less distal femur needs to be cut in a PS knee than in a PS knee, and this improves proprioception. However, there are newer poly options which can allow for PCL substitution. Disadvantages is that a tight PCL may cause accelerated polyethylene wear. I have found many knees in which the PCL was quite tight. I have initially done a lot of PCL retaining knees in my career and moved now more to PCL substituting knees. A loose or ruptured PCL may lead to flexion instability and subluxation. Again, a very simple diagram of a PCL substituting design. And this is the cam and the central polyethylene post. And these engage to reproduce the function of the posterior cruciate ligament. There's a cross section showing through the intercondylar notch that this is what the cam looks like, and this is the polyethylene post. And when these two engage, this mimics the function of the posterior cruciate ligament. Now, for a design has to be slightly more constrained because that requires sacrifice of the PCL. This is a very important gap, which initially I had some trouble when I shifted from a cruciate retaining to a cruciate sacrificing. Resection of the PCL increases the flexion gap in relationship to extension gap. Because the moment you release the posterior cruciate, you get an increase in the flexion gap in the knee. So these gaps have to be balanced. If you're not aware that this happens, then you can have trouble in achieving stability. The femoral component has a cam. This engages with the post that we saw on the last diagram. And the polyethylene inserts are more congruent or deeply dished. The indications are the history of a previous patelectomy in the same patient, reduces risk of anterior-posterior instability in the setting of a weak extensor mechanism, inflammatory arthritis, obviously, because this can continue to erode the PCL, and deficient or absent PCL. It is easier to balance a knee with an absent PCL, and arguably more range of motion and easier surgical exposure. The disadvantages are thought to be that you can get a cam jump if the gaps are not properly balanced. Tibial post polyethylene wear. Some older designs actually had the post break and they required revision for that. Patellar Klunk syndrome, and as I mentioned earlier, additional bone cut from the distal femur to balance extension gap. So how do we decide? Well, literature helps. The posterior cruciate retaining versus posterior stabilized total knee arthroplasty. There's a meta-analysis. It's a bit older now. 8 studies, 888 patients, 963 joints, follow-up up to a maximum of 7.3 years. Now, the post-op range of motion in the posterior stabilized group was 11 degrees more, which is not a huge amount, and flexion was only 2.88 degrees more on average in the posterior stabilized group. And extension, there was no difference. If you see, there's not much of a huge change. If you measure 2.88 degrees, I will measure it as 3, someone will measure it at 1, someone will say it's 4. So not a big difference in flexion, and even extension will not the range of motion is not going to be that much of a clinical significance in these patients. However, what is important is knee society pain scores and knee society function scores. There was no difference between both the groups. And the rate of complications, there was no difference. Now, the clinical measures do not significantly differ despite some change in the range of motion in some studies. Another analysis published in Knee, 9 studies, 1261 knees, significant difference in range of motion, but no clinical difference. Another study, 1114 patients, 1265 knees, no clinical difference between both the groups. In vivo kinematics comparison of posterior cruciate retaining, posterior stabilized total knee arthroplasty under passive and weight-bearing conditions. Now, they say in a PCR retaining knee replacement, an anterior femoral translation from 30 to 60 degrees of flexion was observed. Now, the interesting thing is that the PCL is supposed to prevent this between 30 and 90 degrees. So, the fact that it is still happening may mean that it is not working so well in these patients. Posterior cruciate retention versus posterior stabilization for total knee. Again, a meta-analysis. I forgot to put the year in the journal. This is from 2016, Journal of Arthroplasty, I believe. There was no difference. Survivorship becomes a pretty significant issue. And for that, we look at registry data. There are many registries around the world. And when these registries, they allow us to see at a glance what is the survival going on for these patients. So this is survival analysis of arthroplasty at a minimum. This is a French study, no significant difference in comparing the PCL retaining versus the sacrificing implants. Difference in outcome after cruciate retaining, paper from last year, Journal of Orthopedic Surgery, not much of a difference either. And this one from 2014, similar outcomes again. But registry data, what do they say? Now, the Swedish knee arthroplasty registry, I was quite surprised that I had read this earlier also, but I was thinking that this may have changed with time, that the use of posterior stabilized implants is very rare in Sweden. Only up to 8% of implants are posterior stabilized knees. So it's very difficult to draw a comparison. They've actually not really done an analysis in the Swedish registry on this. The Australian registry, they found a bigger proportion of patients are having posterior stabilized knees. And these two charts are actually very, very interesting. Here they've compared medial pivot design, which is in the yellow, the posterior stabilized knee, and the minimally stabilized, which I believe they mean to be the cruciate retaining. And the cruciate retaining has the least revision rate. The posterior stabilized has a slightly higher revision rate, going on to 18, 19 years. Medial pivot initially follows the pattern of the cruciate retaining, but then with time it slowly increases to match that of the posterior stabilized implant, touching at about the same level at 18 years. Here again, there's a comparison of fully constrained implants to the minimally stabilized implants. Now, as we all know, the hinged implants, which are revision implants or tumor implants, here we'll be talking about hinged implants, which are revision implants, not the tumor ones, that the revision rate is higher. And that is a factor of their basic design. When we connect two moving things, they will wear more. The fully stabilized, for example, the LCCK knee, they will be having lesser wear. And as you go on down, this is the posterior stabilized. The medial pivot initial has a very good survival. But again, at age 17, 18, 19 years, it starts to match that of a posterior stabilized knee. So in the Australian data, the cruciate retaining seems to be doing better as you approach 20 years. But the difference starts at about 4 or 5 years. Now, the complications, what are the complications after PCL substituting TKR? Generally, the same set of complications are present in cruciate retaining and substituting TKR. Some studies do suggest problems in one group over the other, but no consistent complications are actually seen. There's one paper I found from 2018 that there is a problem with contact stress and the contact points on the polyethylene in patients who have cruciate retaining knees, and they have a reduced flexion range of motion. And they were looking at very, very fine points. I really couldn't appreciate what kind of clinical significance this would have in the long term. Okay, so this is the complications from the Cochrane framework, and this just shows the complication the PCR retaining, the PCL retaining and the PCL sacrificing knees, and there are complications across both groups, but not a huge difference in them. So I believe that in the long term, it will be the general complications which are for any major surgery and a joint replacement arthroplasty, which will be across both groups. Some implants may have for one particular one, but generally they are not that far apart as far as complications concerned. This very interesting article I found is pretty old because it's an anatomical study, Journal of Clinical Pathology, and they looked at the PCL ligaments as they were being excised for arthroplasty, and they found that in most patients the PCL was already so diseased, they were raising the question that is the PCL even functional in these patients or not. And since it was just an anatomical study, they were looking at the histopathology of these specimens as they were excised. But it just raised the question, even if we leave the cruciate ligament behind, is it strictly as functional as it would be in a normal, healthy, younger knee? So I'll give you my little personal perspective. Please feel free to disagree with it. I feel that it has to be tailored to the patient's requirement. If a patient is early osteoarthritis, minimal deformity, and ligament laxity, then a CR knee is perfectly adequate. However, in the presence of more advanced osteoarthritis, as we'll be talking about, and as we see, patients with the varus of 20 degrees, flexion contractures of 45 degrees, significant medial bone loss, and sometimes on the femur and tibia both, uh, these patients probably be better served with a posterior stabilized knee. Thank you.
Good. Thank you, Mansoor. We'll move forward. In the interest of time, we'll take questions at the end. Our next speaker is Dr. David Choon from Malaysia, who will be talking about PCL retaining knees. And just as an intro, Dr. David Choon has about more than 30 years of experience, has visited Pakistan multiple times, and we thank him for joining us today. He's a graduate of Sheffield University Medical School, UK, completed his FRCS there, and has received 6 times Civil Award for Excellence from University of Malaya. Currently working in University of Malaya Medical Center, and today his topic is PCL retaining total knee replacement. Over to you, Dr. Choon, please.
Thank you very much, Masood. And I'd like to thank Mansoor Ali Khan for having already discussed most of what I want to discuss. So I'm just going to share my screen. I hope this one works. See that? It should be okay. Actually, one of the aspects of my talk was that I wanted to do a poll through Zoom chat, but somehow or other, I think very few people are actually logged on using Zoom. We may well be broadcasting this through YouTube, so I guess that's going to be very difficult to do. So anyway, so I'm the retired or retiring past president of the Asia Pacific Orthopedic Association, of which Pakistan is a proud member. And as you can see below, we have lots of sections. One of them is the knee section of the APOA. And what we're talking about today is whether we should or should not sacrifice the PCL in knee replacement. This is where I work. It's not very far from you. And quite a few Pakistanis have come to visit me at my medical center. And I welcome any one of you to visit us anytime. Just send me an email, and I will look after you once you get here. Just as Mansoor Ali Khan said, there's no conflicts of interest in this talk. I'm simply advocating a technology that's going to give a better longevity in the long run. As you will see, all implant systems have a CR and a PS variant. And so it's quite easy to look at results from each of these. I was going to get you to also declare what your training was. Were you trained to implant CR knees? as you know, obviously Masood was, or or were you trained to implant PS knees? And I tend to find that your training really kind of determines what kind of knees you believe you should be doing, because that's what your boss has been doing and stuff like that. But there must come a time in your life when you have to think for yourself. And you know, I'm just asking that you declare that you have an open mind and that you're willing to do either kind of knee. And if you feel that you're not very comfortable doing a cruciate retained knee in severe deformity, you're more than welcome to visit us and we'll show you how to do it. So this is my declaration. I have always retained the PCL, and you can see here in the first case on your left that that's a pretty severe deformity in the knee. And we've actually implanted CR knees and actually even put screws to buttress the medial side of the left knee. The one in the middle is not very severe deformity, and the one on the right is not very severe, but these were both bilateral knees and done relatively easily using CR implants. So what I found looking through the registers is that CR knees seem to have better longevity in national registers. Just to show you what I mean, just now Mansoor already showed you this. These are all implants in the Australian registry. These are all implants that are minimally stabilized, and as he said, by their definition, these are cruciate retained implants. These are all implants that are posterior stabilized, right? So there you can really see there's a difference between all implants. Let's just look at the Genesis knee system. So the Genesis knee system, this is your cruciate retained knee. This is their posterior stabilized knee. So at 13 years, there's about 2% difference between the two knees. So really, it's not a huge amount. If you add oxinium to a cruciate retained knee, it actually gives you a worse result. Look at the blue line, which is cruciate retained, and the orange line, which is oxinium cruciate retained. Much worse result. And if you add it to a PS knee, that's like the worst of all. Okay, so the more so-called innovation that we put in, the more variation that we put in, actually, the less good results we get. And this is the Australian registry. These are not small numbers. You know, the CR knees are 14,000 Genesis 2 CR knees done. And they started with CR knees. You know, the PS knees, the 16,000, even more PS knees done. But you can see that the revision rate at 15 years is a bit higher than the CR knees. When you look at the oxinium ones, they're really not doing anywhere near as good as their stainless steel counterparts. Here again, we have the next gen knee, cruciate retain and cruciate retain flex. The flex ones can actually, well, in theory, bend more than the cruciate retain knee, but I've never really tested this out because I don't do that particular implant. But if you go to CR flex and CR, the results are worse again. Again, not a huge difference, maybe 2% difference at 10 years. You know, in your practice, you probably won't notice something like that, but there is a difference. That starts from year one. And again, the numbers of implanted knees, CR flex versus LPS flex, huge numbers, 32,000, 22,000 over a 17-year period. Okay. The Sigma is a bit of an interesting knee because this particular knee, when you look at a PS device, actually it's got a very thick post. And actually, I will show you later in this talk why I think that the PFC Sigma PS knee survives better than all the other implant types you have seen before. But if you add a mobile bearing tray to a PS knee, it actually does worse. All right. And the numbers of Sigma knees put in, most of them were cruciate retained because Sigma was designed as a cruciate retained knee to begin with. But, you know, again, you can see that over a period of time, the posterior stabilized knees and the mobile bearing trays don't do as well as the cruciate retained knees. This is data from the UK registry. These are cruciate retained knees. These are posterior stabilized knees. These are mobile bearing tray cruciate retained knees. And these are mobile bearing tray posterior stabilized knees. You can see, again, as we add more and more complexity to the equation, the revision rate climbs. So why would you retain, the cruciate? Mansoor already said, when I train, I certainly train to do cruciate retained knees. We always thought that there would be more bone conserve, and certainly if you do this in a patient with rheumatoid arthritis, then you're likely to be able to get away with doing an implant without having a medullary support. It's more natural. Well, I don't think that's particularly true. There's more proprioception. Again, I don't think that's particularly true. It lasts longer. Well, that is true. That is definitely true. Okay, and they have better function. Well, it depends on what you define by better function. If you're just taking function as the range of motion, then yes, probably posterior stabilized knees have a better range of motion. But if you're looking at function over a long period of time, and you're adding all those patients that have had to have revisions, then I would contend that a cruciate retained knee probably has, in the general population, a better function than a posterior stabilized knee. Sacrificers would say that, as Mansoor has already said, that you can bend more, and they would also say it's more natural. It's easier to balance. I don't think that's particularly true. In fact, when I came back to Malaysia, all we had was posterior stabilized knees, and I found it impossible to balance because of the severe nature of deformity. I'll explain that in a second. Better function, range of motion, yes, last longer. Really not true at all. Okay, they don't last longer. So why am I saying that we have a problem with the cam and post design? See, one of the things that we like to have in the knee is this thing called rollback. And we would think that sliding, this paradoxical sliding of the femoral component on the tibial insert is not good for the poly. If you go to numerous lectures, they will tell you, yeah, it's bad for poly, it's bad for poly, it's bad for poly. And it results in failure. But as you can see, we do not see those failures. So why are we seeing more failures in posterior stabilized knees? Well, one of the things is this, shear forces. So when you have a cruciate retained knee, you only have shear forces at the distal femoral condyle stroke tibial interface. You do not get this shearing force that occurs between the cam and post. Now, this happens to be a PFC knee, so it's a very big post, so that post takes a long time to wear out. And I have a suspicion that if you follow that Australian cohort for long enough, there will start to be a divergence between the CR and PS knees. And the reason would be your post is wearing out. All right. Also, if you bend that knee back enough, which you would do with rollback and a cam and post design, you're going to get posterior stress. And if you haven't done that knee properly, you're going to end up with all these problems. I have never, ever seen, I've done thousands of knees. I have never, ever seen this kind of problem occurring in a CR knee. You can have some pretty challenging knees like this. And you can see that in these patients, the limb axis is non-normal. Notice how there's so much more external rotation and very little internal rotation. I'm going to display that one more time for you. More external, less internal. That's quite common. I'm sure it's the same in your patients because our people like to sit cross-legged on the floor, okay? And because of that, you have external tibial torsion. See where my finger is pointing? That's the tibial tubercle is usually very externalized in our patients. And when you look at the medial defect, it's usually posterior medial defect on the tibia, and that's the both tibia and probably both femur as well. It's all part of this culture of squatting, I guess. All right, sorry. So, and certainly it's a very Chinese problem. This is a very common thing, and this in China, and this was a report from Hong Kong. PK Chu, my friend Peter Chu, and WM Tang has also reported this in Hong Kong population. Okay, the tibia is not normal. It is bowed and it's got this huge medial ossified because our patients wait a long time before they come for knee replacement. Many times patients would rather die than have surgery, but there you go. They've got to the point where they just can't get about and they need surgery. So you really need to address a lot of these issues, which you also see in your population, no doubt whatsoever. Okay. The medial collateral ligament is tightly held by osteophytes, and those osteophytes are huge, and the MCLs usually tight. Okay. And the lateral collateral ligament is very, very lax. So if you have a lax lateral collateral ligament and a tight medial collateral ligament, and if you sacrifice the PCL, you're forced to make minimal bone cuts, reinforce your tibial tray with a rod, and also you're going to have to completely loosen off your MCL to balance your LCL. All right. If however your medial collateral ligament is intact, the distance between your femur is by the PCL. That's also a challenge. Many people find it very difficult to balance these knees because there's a flexion contracture and the PCL arises itself from a tibial ossified. So if you don't do a posterior clearance of all these structures, you're going to have problems with your cruciate retained knee. So as you can see, I have a preference for cruciate retention, and this is a set of bilateral knees I've done. I would agree with you that this is not possibly the worst kind of knees you see in Pakistan, but I've actually seen worse knees than this as well, and they're all done with cruciate retained knees. One of the things you discover that when you do this kind of knee with a cruciate retained implant, because the distance between the femur and the tibia is maintained, even in moderately severe deformities, we're only using 8 to 10 millimeter inserts. We're not really using very, very large inserts. You need to do a sleeve release of the medial side, as I said. And once you release all those things, the medial is loose, the lateral is loose. The only thing that keeps your knee together is your PCL, okay? So if you sacrifice the PCL, that's the end. You're talking about constrained implants, you're talking about all sorts of things, which are really not needed actually, and adds to the cost for your patient. All right, so I'll say to you again that the PCL is needed to stabilize the joint. So these are just some of the things we do: a ligament release, osteophyte resection. But you see, and those posterior osteophytes behind the PCL, very important to clear them. If you don't clear them, if you don't see it, like on the right, your PCL is really going straight up into the femur, then you haven't released enough of the osteophytes at the back of that PCL, and you're going to end up with problems with flexion extension imbalance. Okay, we always cut off the osteophyte, and then, but once you do it, the knees are perfectly well balanced, really no problem at all. Okay, so finally, this is the difference between the two implants, preoperative and postoperative. Okay, so as Mansoor has said, really there's no difference. Lots of studies have said in terms of actually function, and these are Asian studies. There's no difference between the two types of implants used, and these are my own patients with CR knees. Okay, so I would say to you that a simple cruciate retained knee replacement is more likely to get better longevity than other designs. Thank you very much. This part really was, again, to get you to at least partially agree with me that, based on this data, there's some reason to think that if you are doing a cruciate sacrifice knee, you should really be considering doing a cruciate retained knee.
Thank you, Dr. Choon. Indeed, as you said in your first sentence, a lot of it has got to be in your initial training. What were you trained as? So we'll continue with the discussion at the end. A lot of rich material getting accumulated for discussion. both pros and cons of cruciate retention versus sacrificing. So let's move on. We move to Dr. Nasir, who will take us through mobile bearing knees, another option for, as we mentioned, our topic today, advanced osteoarthritis of the knee. So mobile bearing knees. Over to you, Dr. Nasir, please.
Thank you very much, Dr. Masood. Bismillahirrahmanirrahim. Okay, my name is Dr. Nasir and I work as a business consultant and assistant professor in Liaquat National Hospital and Medical College. Thank you very much, Dr. Masood, for allowing me to present. And it's very nice to see you, Dr. David Choon. The last we met was in Bali, and it was a nice meeting there. And I always remember you as a good person. I have a photograph of you with me. Sometimes we can share it. Now we'll quickly move on to the presentation. So we'll see how the concept came into being actually. Now in the early 70s and 60s, actually, the aseptic loosening was the main confrontation for the arthroplasty surgeons. And the reason was that was a very high stress design and very less understanding of the biomechanics, which was leading to malalignment and instability. The poly structure was not very well understood, and also the way of sterilization and the backside wear and the fixed bearing was a problem. So seeing all these actually was a problem, and then Mr. Fred Beekle with his colleague Michael Papas, he designed the rotating platform knee in the mid or the late 70s. Now, the idea was to convert the high stresses into low stresses of less than 10 megapascal. And this was done by increasing the radius of curvature of the poly and changing the articulation. Okay, and this is how actually the poly wears with the multi-directional movement on one articulation. So it's in the galaxy of the knees. It is here the first LCS when it was launched around 1977 and 78. And once it was launched, the concept was that the knee is having multi-directional movement, and when it flexes, it is not only that it is flexing, but obviously there is a roll back when it glides back, as well as it slides, and it also have an axial rotation because the lateral femoral condyle rotates more than the medial femoral condyle. So it leads to an axial rotation. We can say that the femur rotates externally on the tibia, or we can say that the tibia rotates internally on the femur, and that creates an axial rotation. So this axial rotation was then transferred to another articulation between the poly and the tibial base placed on a very highly polished surface. So what happened that the high contrast stresses on one articulation were then transferred in two articulation and theoretically causing the advantage of less wear. And Walker et al. Has found that unidirectional movement on the poly actually causes less wear because it causes the molecules to align along with that movement. So after proposing this concept, the first paper which came out from Beekle and his colleague was in 1986, where he showed the result of 123 of his cemented total knees, in which he showed that he had a very good an excellent result in 88.6% of his cases. And he showed that he did not had any mechanical implant failures and he did not had any meniscal bearing dislocation. But we know that all the mobile bearing knees are not the same. And Walker et al. Has classified them into four types. Now, the first design, type 1, is the one in which there is a cone-in-cone design. There is a central peg on which the poly rotates in only one direction. Type 2 and 3 are the ones which also allows some mediolateral and an AP translation, which happens in the meniscal bearing type of the design. And the type 4 is the guided design, which allows rotation and translation guided by the cams. So the result of all the mobile bearing is not the same. So this is a concept, if you can see over here, that this A is basically and B is showing the rotational movement of the rotating platform, which is a unidirectional movement. while the other is showing the AP as well as the medial lateral movement, which happens in this meniscal type of mobile bearing. So these kind of implants failed very early because of, again, the multi-directional movement going on between the tibial plate and the poly, and that was not the desired result which we wanted. So studies have shown that out of all these poly, the type A, that is cone on cone design, is one of the most successful design as it is shown in the picture. Now this is PFC sigma with a fixed bearing, and this is the RP design with a highly polished surface of the tibia with the articulating poly, which is a cone on cone design. Now, talking about the theoretical advantage of the mobile bearing knee, which actually basically what we wanted to have is, number one, it increases the conformity of the poly onto the femur, and which actually increases the contact area. And by increasing the contact area, it reduces the contact stress on the poly. And number two, it decouples the complex multi-directional movement which is going on a single articulation into two different articulation, and converting the multi-directional movement into unidirectional movement, thus causing lesser wear. The third theoretical advantage, which it is anticipated, is the accommodation of the rotational alignment of the tibia, which in turn will improve the patellar tracking, which is one of the major problem in the post TKR issues. And the fourth is the reduction of fixation stress, especially in the constraint design. Now we are going to see one by one what the literature has to say about all these theoretical advantages. So these are the paper which actually say that obviously the unidirectional movement does reduces the polywear. And these are another paper which shows that the rotation of the poly does increases and allows the accommodation of the malalignment of the tibia. And another paper which has been seen, and Douglas A. Dennis showed that that the movement of the mobile bearing knee does not stops improving over a period of time. Rather, he found out that if a knee mobile bearing is rotating by 8.5 degree at 3 months, later on he found that that rotation increased to 9.8% in 15 months postoperatively. So
is your PCL. Okay, so if you sacrifice the PCL, that's the end. You're talking about constrained implants. You're talking about all sorts of things which are really not needed actually, and adds to the cost for your patient. Right. So I'll say to you again that the PCL is needed to stabilize the joint. So these are just some of the things we do: a ligament release, osteophyte resection. But you see, and those posterior osteophytes behind the PCL, very important to clear them. If you don't clear them, if you don't see it, like on the right, your PCL is really going straight up into the femur, then you haven't released enough of the osteophytes at the back of that PCL, and you're going to end up with problems with flexion extension imbalance. Okay, we always cut off the osteophyte, and then, but once you do it, the knees are perfectly well balanced, really no problem at all. Okay, so finally, this is the difference between the two implants, preoperative and postoperative. Okay, so as Mansoor has said, really there's no difference. Lots of studies have said in terms of function, and these are Asian studies. There's no difference between the two types of implants used, and these are my own patients with CR knees. Okay, so I would say to you that a simple cruciate retained knee replacement is more likely to get better longevity than other designs. Thank you very much. This part really was, again, to get you to at least partially agree with me that, based on this data, there's some reason to think that if you are doing a cruciate sacrifice knee, you should really be considering doing a cruciate retained knee.
Thank you, Dr. Choon. Indeed, as you said in your first sentence, a lot of it has got to be in your initial training, what were you trained as? So we'll continue with the discussion at the end. A lot of rich material getting accumulated for discussion, both pros and cons of cruciate retention versus sacrificing. So let's move on. We move to Dr. Nasir, who will take us through mobile bearing knees, another option for, as we mentioned, our topic today, advanced osteoarthritis of the knee. So mobile bearing knees. Over to you, Dr. Nasir, please.
Thank you very much, Dr. Masood. Bismillah ar-Rahman ar-Rahim. I hope all of you can see. Thank you. Okay, my name is Dr. Nasir and I work as a business consultant and assistant professor in Liaquat National Hospital and Medical College. Thank you very much, Dr. Masood, for allowing me to present. And it's very nice to see you, Dr. David Choon. The last we met was in Bali, and it was a nice meeting there. And I always remember you as a good person. I have photograph of you with me. Sometimes we can share it. Now we'll quickly move on to the presentation. Okay, so we'll see how the concept came into being actually. Now, in the early 70s and 60s, actually, the aseptic loosening was the main confrontation for the arthroplasty surgeons. And the reason was that was a very high stress design and very less understanding of the biomechanics, which was leading to malalignment and instability. The poly structure was not very well understood, and also the way of sterilization and the backside wear and the fixed bearing was a problem. Seeing all these actually was a problem, and then Mr. Fred Beekle with his colleague Michael Papas, he designed the rotating platform knee in the mid or the late 70s. Now the idea was to convert the high stresses into low stresses of less than 10 megapascal, and this was done by increasing the radius of curvature of the poly and the changing the articulation. Okay, and this is how actually the poly wears with the multidirectional movement on one articulation. So it's in the galaxy of the knees. It is here the first LCS when it was launched around 1977 and 78. And once it was launched, the concept was that the knee is having multi-directional movement, and when it flexes, it is not only that it is flexing, but obviously there is a rollback when it glides back, as well as it slides, and it also have an axial rotation because the lateral femoral condyle rotates more than the medial femoral condyle, so it leads to an axial rotation. We can say that the femur rotates externally on the tibia, or we can say that the tibia rotates internally on the femur, and that creates an axial rotation. So this axial rotation was then transferred to another articulation between the poly and the tibial base placed on a very highly polished surface. So what happened that the high contrast stresses on one articulation were then transferred in two articulation, and theoretically causing the advantage of less wear. And Walker et al. Has found that unidirectional movement on the poly actually causes less wear because it causes the molecules to align along with that movement. So after proposing this concept, the first paper which came out from Beekle and his colleague was in 1986, where he showed the result of 123 of his cemented total knees, in which he showed that he had a very good an excellent result in 88.6% of his cases. And he showed that he did not had any mechanical implant failures, and he did not had any meniscal bearing dislocation. But we know that all the mobile bearing knees are not the same. And Walker et al. Has classified them into four types. Now, the first design, type 1, is the one in which there is a cone in cone design. There is a central peg on which the poly rotates in only one direction. Type 2 and 3 are the ones which also allows some mediolateral and an AP translation, which happens in the meniscal bearing type of the design. And the type 4 is the guided design, which allows rotation and translation guided by the cams. So the result of all the mobile bearing is not the same. So this is a concept, if you can see over here, that this A is basically and B is showing the rotational movement of the rotating platform, which is a unidirectional movement, while the other is showing the AP as well as the mediolateral movement, which happens in this minuscule type of mobile bearing. So these kind of implants failed very early because of, again, the multi-directional movement going on between the tibial plate and the poly, and that was not the desired result which we wanted. So studies have shown that out of all these poly, the type A, that is cone on cone design, is one of the most successful design as it is shown in the picture. Now this is PFC sigma with a fixed bearing, and this is the RP design with a highly polished surface of the tibia with the articulating poly, which is a cone on cone design. Now, talking about the theoretical advantage of the mobile bearing knee, which actually basically what we wanted to have, is number one, it increases the conformity of the poly onto the femur, and which actually increases the contact area. And by increasing the contact area, it reduces the contact stress on the poly. And number two, it decouples the complex multi-directional movement which is going on a single articulation into two different articulation, and converting the multi-directional movement into unidirectional movement, thus causing lesser wear. The third theoretical advantage, which is anticipated, is the accommodation of the rotational alignment of the tibia, which in turn will improve the patellar tracking, which is one of the major problem in the post TKR issues. And the fourth is the reduction of fixation stress, especially in the constraint design. Now we are going to see one by one what the literature has to say about all these theoretical advantages. So these are the paper which actually say that obviously the unidirectional movement does reduces the polywear, and these are another paper which shows that the rotation of the poly does increases and allows the accommodation of the malalignment of the tibia. And another paper which has been seen, and Douglas A. Dennis showed that that the movement of the mobile bearing knee does not stops improving over a period of time. Rather, he found out that if a knee mobile bearing is rotated later on, he found that that rotation increased to 9.8% in 15 months postoperatively. So
Is your PCL, okay? So if you sacrifice the PCL, that's the end. You're talking about constrained implants, you're talking about all sorts of things, which are really not needed actually, and adds to the cost for your patient. Right. So I would say to you again that the PCL is needed to stabilize the joint. So these are just some of the things we do: a ligament release, osteophyte resection. But you see, and those posterior osteophytes behind the PCL, very important to clear them. If you don't clear them, if you don't see, like on the right, your PCL is really going straight up into the femur, then you haven't released enough of the osteophytes at the back of that PCL, and you're going to end up with problems with flexion extension imbalance. Okay, we always cut off the osteophyte, and then, but once you do it, the knees are perfectly well balanced, really no problem at all. Okay, so finally, this is the difference between the two implants, preoperative and postoperative. Okay, so as Mansoor has said, really there's no difference. Lots of studies have said in terms of function, and these are Asian studies. There's no difference between the two types of implants used, and these are my own patients with CRNAs. Okay, so I would say to you that a simple cruciate retained knee replacement is more likely to get better longevity than other designs. Thank you very much. This part really was, again, to get you to at least partially agree with me that, based on this data, there's some reason to think that if you are doing a cruciate sacrifice knee,
He invented and introduced the world to the inside-out technique, the perimeniscal abrasion techniques, and the fibrin clot. But unfortunately, meniscectomy is still the most commonly performed arthroscopic procedures globally. I don't know why. I'm guilty. Maybe I'm one of them who used to do that as well. So what we have learned from the historical perspective, this was the first study that came out in 1948, and they said that perhaps the meniscectomy can cause the ridge formation, narrowing of the joint line, and the flattening of the femoral condyle, but he couldn't really establish the link between the meniscectomy and the occurrence or happening of the arthritis. So what we needed is the long-term studies that could really establish the fact that the meniscectomy is harmful for the knee joint and its biomechanics. So we looked at this paper published in 2004. They did a follow-up, 21 years follow-up after meniscectomy, and they suggested that 71% of the knees did develop a mild, but alarmingly, 48% knees had more advanced arthritic changes. We looked at another paper, and this is published in 2016, almost 20 to 30-year follow-up. 3 out of 4 patients had developed radiographic tibiofemoral osteoarthritis, and 1 out of 4 had developed patellofemoral arthritis. So yes, now we have the reason. We know the meniscectomy can cause arthritis. The more problematic are the ones who are in their peak prime working years, like the age group between 30 and 45. And now, because we are more concentrated on preserving the meniscus, we have better investigation to identify those lesions, and we have better repairing techniques to preserve those. So the next question is, what can we say? We know the common types of the meniscus. We know the blood supply of the meniscus. We know there is a red zone, the red-white zone, and white zone. So anything that falls in the red zone is bound to heal. Red and white, we are still not sure, but we are hoping that it will heal. And white zone is still a dilemma for us. But having said that, we need to look at the incidence of meniscal tear with ACL injury. So we know ACL is a traumatic injury. Any tear of the ACL is a traumatic. So what percentage of the knees will have the meniscal tear? So this was the paper published 2015, almost 80% knees. More seen in patients who were left for more than 2 months. The incidence of meniscal tears were more, probably perhaps the wear and tear or the abrasion, and that may have caused it, not sure. So now we know that 80% of the knees with ACL tear will have meniscal tear. So where exactly it is? It's in the peripheral 1/3, more common in the peripheral 1/3. Good news, it means the peripheral 1/3 has a better blood supply, so we can save it. We should try and save those meniscus. Okay, so the next thing is, where is it located? Is it anterior or posterior? Anterior would be a lot easier, not required much of the learning curve, but unfortunately, the more meniscal tears associated with ACL injury lies posterior. So it means there's a steep learning curve, and you need to be careful, because when you're repairing those meniscus, you're very close to the neurovascular bundle, and there are reports suggesting the nerve injury and arterial injury with the meniscal repair. So you have to be careful. So with all this, we have the indications now. We can treat the acute tears, peripherally located, well-vascularized zones, and which are longitudinal, vertical in orientation. And we have extended our indication to the horizontal cleavage tears, the root tears, tears in the red-white zone. However, we are in this area. So if you're going into the OR, possible the inside out or the outside in, or all inside in techniques, whatever is available. And if there's nothing available, just remember, do not remove it, because removing will cause more problem. So if you remove it, what about the healing rate? This is the trial conducted by the Moon Group, which is the multi-center orthopedic outcome network. And they said that it doesn't matter what kind of material you want to use, the healing rate is almost in the region of 95%. Because remember, most of the tears are in the peripheral 1/3. So if they are in the peripheral 1/3, They are in the red zone. So no matter what you use, you will get it healed. We still have a problem though with the avascular tears in the avascular area, and that's what the future we're looking at. The orthobiologics, they're looking at the PRP augmentations, the bone marrow aspirates, and there's still trial going on for the PRP for the meniscal repair. The orthobiologists, maybe they'll have a role. Another thing they're looking at by the help of biomedical engineers, clinicians, and industry leaders to develop a meniscal implant. So that's everything is in pipeline. So hopefully in near future, we will have more things available to save the meniscus. So we have come a long way from the slogan raised by Smiley in 1967 to take it all out from saving the meniscus. Thank you.
Thank you very much, Dr. Yasir Khan. It's a very informative talk and very thorough. So we'll quickly move to our next talk. So we should have some time left before Professor Fernandez leaves us for some discussion. So next talk, Dr. Malik has joined us, I think.
Naveed, I think Atif is in theater. He just texted me. He probably got stuck in theater. So maybe you should start your talk and then he's joining now. He just texted me. He's joining now. Okay. So either we should wait for him or you can start your talk and we give him the next.
Yeah, that should be fine. So I can, I'm ready, so I can join. I have a very quick talk, so obviously a little bit different topic than what we'll be talking about, but it's a very quick talk.
So your talk start. I'll just text him now. He's starting. So I think he's joining. Saad, if you can kindly see if Atif has joined us.
Oh, sure, I can check it.
We sab aap shuru kar dein.
Yeah.
In the interest of time.
So this will be a brief talk, so I will go quickly. So management of ACL injuries in children and adolescents. But obviously it's a hot topic, so there are many controversial issues here. So no disclosures to made. So we don't, obviously it has been noted in last 2 decades that the incidence has been rising due to various reasons. Obviously more children and adolescents are involved in sports activities happening more and more at a school level. So in 1994 to 2006, in 2 decades, in US, the ambulatory ACL procedures in patients less than 15 years old increased by 924-fold. It's a significant increase in the number. But there are important questions to answer when we are dealing with ACL injuries in children. Most important are that do children who rupture their ACL mature similarly to their uninjured peers, and do they continue to sports, and do they prioritize their education and other interests over sport? And does an ACL injury and treatment change their lives? So these are very important questions. So we don't have any long-term thorough studies, rigorous studies performed. Obviously, most of the studies are done on adults, and which can give some input, some thought into the children. So mainly, just like most adult studies show that after 10 years of ACL injury, if it is untreated, people develop arthritis. So if a 10-year-old child develops ACL injury, so where he will be standing at 20 years of his age. So these are very important questions to answer. So how can the clinician prevent ACL injury in children? So role of prevention is very important. How does the clinician diagnose? So diagnostic test and imaging very important. And what are treatment options? So we will have a look on those. And what are the most important considerations when making treatment decisions? So skilled age assessment is very important. So there are different methods for that. Most commonly done is the PA view of the wrist, and then you can do the X-ray of the knee as well. You can do the riser grading. You can do the tenor staging. So that is very important question when you are dealing with that question. So the most important question which will assess, which will affect your decision making is the actual scheduled age of the child, and the factors to take the decision to construct or to go conservative, and then what are the children's role and responsibilities, clinicians, and then a civil consideration. Injury prevention is very important because of 2 reasons. One, obviously, the ACL injury has a very bad prognostic factors if it left untreated in children, and obviously because of children than adults. And we know there are compelling evidence that ACL injury prevention programs work in skeletal mature patients. So from that, we have inferred that they will work a similar way in the children as well. And there are some high quality injury prevention programs are the first line defense against the potential negative short and long term consequences of the ACL injury. They are straightforward programs, do not require much instrumentation or do not require much manpower, so they can be utilized at the children's educational or institutions or children's sports clubs and even at home as well. So one well-established injury prevention program, the 11 plus, has recently been modified. It was for this program was for adult by generated proposed by the FIFA and to suit the pediatric population. So how to diagnose? The history examination and clinical tests and imaging is the routine algorithm. So hemarthrosis, acute swelling in the knee within 24 hours after trauma due to intra-articular bleeding following acute knee injury is an important clue suggesting structural knee injury. So it has been estimated that almost 60% of the adolescents who present with acute hemarthrosis have ACL injury. So the incidence is very high. The suspicion should be very high when you see a child with hemarthrosis after trauma. And usually they are non-contact injuries, especially in female children. They are non-contact injuries due to various reasons, intrinsic and extrinsic. And due to immature skeleton, children may sustain different knee injuries, including the sleeve fracture of the patella and epiphyseal acid than adults. So you need to do X-rays first, epilateral tunnel and skyline view, as Dr. Masood has also described. So in children, tibial eminence fracture or avulsion is more common, maybe more common than the actual ACL rupture. MRI is obviously the gold standard. And if the child present with the locked knee, you should do an acute MRI to see if it requires urgent intervention. So the issue is that the negative predictive value of clinical examination MRI for ACL, tear, and meniscal pathology are higher than the positive predictive value. So if the examination is normal and MRI is not suggesting tear, so it's likely the child does not have the tear. But in diagnosing, you might miss them if they show everything. I mean, if the examination is positive, MRI is showing something, it's not showing something, you may miss it. The goals, what are the treatment goals? To restore a stable, well-functioning knee that enables a healthy, active lifestyle across the lifespan, to reduce the impact of existing or the risk of future problems, which may be related with the instability of the knee, and to minimize the risk of growth arrest and femur and tibia deformity. Obviously, when we are talking about the surgical intervention. Treatment options are usually you can consider in two groups: high quality rehabilitation alone, which is the non-surgical treatment, and ACL reconstruction with high quality rehabilitation. You cannot separate high quality rehabilitation from the from the surgery. So both have to go and simultaneously, especially in kids. So without high quality rehabilitation, ACL surgery, how well it is done, may not prove fruitful, may not give that results, and vice versa. So what is high quality rehabilitation? Critical component, it is the critical component in the management of ACL injury. But obviously children are not small adults. The exercise program has to be tethered, or you can say based on their demand, their needs. Exercises and functional goals must be modified, not simply copied from the adult oriented rehabilitation protocol. And what is important is that the dynamic multi-joint neuromuscular control is the primary focus of ACL rehabilitation in children. So in young children, obviously with markedly open fascias less than 12 years, there is less emphasis on the development of muscular strength and hypertrophy. But in relatively older adolescents, where the growth potential is not much left, more than 14 or 15 years, so the same adult protocol can be followed. Emphasize exercises that facilitate dynamic lower limb alignment and biomechanically sound movement patterns, gradual progression to different phases. So rehabilitation phases are usually divided into 4 phases. I'm not going into the detail, but you can see for patients who want to choose surgery, there's a pre-rehabilitation phase. So you must have full active extension and at least 1 degree of knee flexion, little or no fusion, ability to hold terminal knee extension during single leg standing. And for adolescents, almost 90% of limb symmetry on muscle strength test is compared to the opposite limb before you go for surgical intervention. So acute surgery is usually not recommended. So how to progress? Obviously, non-surgical treatment should last for at least 3 to 6 months. Postoperative rehab should last for at least 9 months or a year before return to full participation in preferred physical activities. The young athletes are at higher risk for second ACL injury following reconstruction. And obviously, the risk is more in first 12 months post-surgery. So what are the indications? So 3 most important indications: the child has repairable associated injuries that require surgery, that include the meniscal tear or tear of the other ligaments or any osteochondral defects or any fracture. So obviously, these are straightforward indications. When you go for repair or treatment of that injury, you should consider ACL as well. Or the child has a recurrent symptomatic knee giving away after completing high quality rehab, or the child experiences unacceptable participation restrictions. So obviously he has to modify a lifestyle which is not acceptable for his age. So again, you go for surgical intervention. What are the techniques? So these are general principles. Use a well-positioned soft tissue autograft of adequate size with adequate fixation to allow functional rehabilitation. Physical damage should be minimized to avoid growth disturbance, and bone plugs and fixation device should not cross the physis. There are different techniques. One is the transphysial, the physial sparing, and the partial, or you can say incomplete transphysial. So transphysial can be considered just like adult, just like we do in adult. So it can be considered in older children who are tender stage more than 3 and skeletal age is more than 12 years, in girls and more than 13 years in boys. And it is physial, transphysial, but you can say it is a physial respecting transphysial technique, a little bit modified from the adult. Single bundle quadriceps hamstring is usually used. Diameter of tunnel should be such that it should incorporate less than 9 millimeter graft, should not be a very large tunnel. So this is how it looks like. So the graft is obviously traversing through the physis. But why the femoral tunnel looks like this? So we will come to later on. So coming to physial sparing, so where you don't want to injure the physis, you have 2 different methods. One is the extra physial iliotibial bend autograft reconstruction. It is the old modified McIntosh technique. So you can consider in relatively younger children, less than 11 years old, and girls, and less than 12 years old in boys. Outcome has been reported in many literature. So there are excellent outcome with these techniques. The re-tear rate is 4.5% with 2.1% rate of arthrofibrosis and 0.4% rate of septal arthritis, and no limb length and angular deformities has been reported with this technique. So this is how it looks like. So a central portion of the ITB is taken and then looped around posterior femur, and then under the meniscomeniscal ligament tied over the anterior cortex of the tibia. So it's the intra and extraarticular, both components are there. So another technique to spare the physis is the all epiphyseal technique. So you do not cross the physis, but you stay your fixation and your graft stays entirely into the epiphysis. So this is also a very good technique and routinely done now because of the development of more instruments like flip cutter. So people do this technique more often now, and the graft rupture rate is 4 to 17%, and MRI-based investigation noted physical compromise in 15 to 20 tibia and 4% of 23 femora. So despite this technique is known as all epiphyseal, but there are problems with this as well. So if you are too close to the physis, this may damage physis, and there are reports which are showing physeal compromise, but may not be showing too much limb length discrepancies. So this is how it is done. So all your graft is in the epiphysis, under the physis, in both in tibia and the femur. So, and then the technique is a partial transphyseal ACL reconstruction, where you can combine the extra-articular graft from the femur side to the articular graft from the tibia side. So how it is evident, and this can also be done in, you can say, children who are very close to maturity, where the tibial physis may not give much problem. What are the surgical principles and techniques to reduce the growth disturbance? So there are 3 main principles: drilling at the periphery of the physis and the perichondral ring increase the risk of growth disturbance. You should avoid that. Bone to drill hole should be as vertical as possible and as central as possible, and do not cross the epiphysis with hardware, implants, or bone blocks. fill bone tunnels with soft tissue rather than leaving the tunnels open. So this is a very important slide. So there are three different ways of making a tibial femoral tunnel. A is the transtibial, or you can see the more vertical tunnel. It is the old transtibial method, but maybe more preferable in the pediatric population. So this method versus B, which is the more anatomically oriented tunnel, but it's injuring more part of the fasces. So animal studies have shown that if you injure more than 7% of the epiphysis, this may lead to growth disturbance. And then obviously tunnel C may not be very much anatomically oriented, but it preserves the fasces as much as possible. Graft trials should be a soft tissue graft. You should not do a BTB in children to avoid damage to the patellar epiphysis. No allograft, because reports have shown that it's not, there are very high revision rates with allograft in children. There's a new technique of living donor allograft of the hamstring tendon. So maybe parent or something can be tried, but no long-term studies are there. And obviously you go for extracortical fixation, not the screws or something. Graft incorporation is very considered good because children are growing, they have a good healing potential. Adaptations and remodeling of the child, you have to consider in mind. The studies have shown the graft elongates as the child grows in the height, but it do not progresses in the diameter. So there's a double problem here. So on the one hand, to preserve the fasces, we want our graft to be to tunnel more vertical, but on the other hand, if the graft elongates further, and it's not increasing the diameter, this may even make it more vertical and cause instability as the child grows. Now the question, to operate or not to operate. So children who undergo ACL reconstruction after failed non-surgical management may have a higher number of meniscal and chondral injuries at the time of ACL reconstruction compared with those who undergo early ACL reconstruction. So this is also my observation as well. My population is usually adolescent, not very young children, 15 or 14, 16 years around, the couple of cases which I have done. And this is what I have noticed, who come late and who stay for non-operative treatment for a while, they show more meniscal and injuries, which was not evident in their earlier MRIs. The number of instability episodes prior to surgery appear to be a more important factor than the length of the time between injury and surgery. The non-surgical treatment is a viable and safe treatment option in skeletally immature patients who do not have associated injuries or problems. Abandoning non-surgical treatment in favor of ACL reconstruction is an option if the child has recurrent instability and obviously he has problems with daily activities. Now, what are the risks associated with ACL reconstruction? Important risk is the growth disturbance can be of three types: localized growth disturbance due to the fascial damage, or generalized growth disturbance due to the pressure, tight pressure of the tight graft, or it may be overgrowth due to hypervascularization sometimes. Second risk is ACL rupture, almost 13% rate of the same graft rupture, and congenital ACL rupture 14%, because these are young children, very active population. And if you have more injuries to deal with, the poor long-term knee health is an issue. So knee stiffness is a problem which can be due to the injury, which can be due to the surgical intervention or inadequate rehabilitation. Infection rate is just like adults, 0.19%. So this is a quick algorithm. So if you are suspecting a child with a ACL injury, and go for MRI to evaluate. If there is a partial tear and less than 50% is involving only AM bundle, grade 1 pivot shift, and he is less than 14 years of age, go conservative. If it is stable, he can progress to the full activity. If there is continuous stability or there is a complete ACL tear, then there is a different algorithm based on the age of the patient. So either you go for, in children who are close to skeletal maturity, go for fascial, just transphysial, just like adults, and who are away from skeletal maturity, less than 12 years or less than 11 years, fascial sparing, either all epiphyseal or extraphyseal, and then progress to full recovery in a year. So I hope this has covered the topic. So we are really...
Naveed, if I interrupt in the middle, Julio wants to go for his meet answer before he heads to the meeting.
Yeah, that would be nice.
Yeah, excuse me, guys. I have a meeting at starting at 8 here in Montreal for the mentorship committee meeting. So if you have any questions, otherwise I'll have to leave you guys. It's a wonderful, wonderful meeting. It's really, really exciting to see that going on, and I'm available for. Yeah, it depends on your technique. You know, I presented that in a 30 millimeter interarticular length. So shorter grafts can be used for an all inside. People that like an open tunnel on the tibia needs a longer graft. So you're going to go after 9 millimeter graft. So you cannot go any further, getting the tendon, the quad tendon. So we have to add on the distal side, which is bone. So that's basically it. I mean, as far as soft tissue incorporation into the grafts, into the tunnels, I think there's this discussion this has been going on, and we have answered the questions already. So it goes well.
Julio, I have a question for you. So,
Sure.
Number one, I was trained in posterior stabilized. During our training, we did use the cruciate retaining, and there was one knee, and I was trying to remember its name, in which both the ACL and PCL both were saved. And the few knees which I did during my training, I saw that the middle piece which was saving, trying to save both ACL and PCL, was usually so loose that we ended up trying to cement it down. So I don't know whether it was worked or not, but it never convinced me. Plus, I think there was 4 or 5 years ago, if I'm correct and my memory serves me right, that there was an article in JBJS in which they studied posterior cruciate retaining knees, and they found that after 1 to 2 years, almost all of them, the cruciate, posterior cruciate was non-functioning. So I don't know what helps or not. Main thing which I have learned is that whichever knee you do, the best one is the one which is done correctly according to the recommendations, and the soft tissue balancing has to be just precise. And if you do that, then usually you have no problems, and you can get good results with the. But I have found that what Dr. Choon was saying, that in our part of the world, people do not come for total knee replacement until they are just about at their last leg and they can't even move, and there is severe deformity. And to do that, we try.
Okay, we will, in the meanwhile, we'll open the floor for questions and discussions. We have a good number of participants. I'm sure all of you are engaged in some kind of form of knee arthroplasty. My big brother, very good friend, Professor Shams, I can see him in the audience. So considering his greatness, we can give him the first mic. Shams bhai, any question? Comment?
No, I am enjoying the meeting and the match.
I can see that, sure. David Choon, you want to say something?
If anything, I'm just going to share my screen and just show you that contrary to common belief, it's actually possible to do a cruciate retained knee in severe deformity. So this is actually, this is an 85-year-old lady who was the mother of 2 physicians who, like, for some reason, let her just go like this until she decided that she needed to have surgery. And this is a pre-op X-rays. I would say that maybe, this is typically Pakistani. I don't know. What do you think?
Very much Pakistani.
Huh? That's what you see, right?
Yes, a lot of them poor, they never make it to the OR. They just cannot afford. That's another aspect of this disease.
Actually, I used to have patients tell me, Sonny, if it's going to cost that much, I'll sooner save it for my funeral. Thank you very much.
Yeah, or for their family, exactly.
So you you make your cuts. You can see there's a huge gap in there, but the PCL is always intact in these cases. I don't know if you can see that. That's the PCL there, and then you can see the PCL again just there, right? There's a huge hole, and so we filled it with a stemmed tibial prosthesis to tray. But you can see actually that is not a very thick insert we put in. So if you can restore the normal anatomy of the joint and preserve the PCL, you can get actually very good results, even with the CR knee. So there you go. That's just it. I know that this knee survived at least 5 years because I have friends in this. This is another city, so yeah, she was pretty happy with the result.
What is the incidence of an absent PCL in such cases? Once you're committed for a PCL sacrificing implant and you go in and you don't find a PCL or it's very attenuated.
Well, there's always a PCL. Okay. In fact, I trained in Boston where they developed cruciate retained implants, and there's always a PCL. Problem is when you certainly when I first started doing them, we had all the cases were like that lady I showed you, almost every single one. And trying to balance them when you're very inexperienced, I was at the time, it was a real major problem. And sometimes in trying to loosen off the cruciate you would end up just completely, detaching it. And I still put in a cruciate retained implant, and none of these knees actually had any problems. So, there was somebody who quoted just now. There's the paper that says after a while the PCR doesn't function. Well, it doesn't have to function. In some ways, the posterior capsule also substitutes for your as well.
All right. So you said they would last just 5 years. Why did you say that?
No. That particular lady, I know it lasted her 5 years because I don't know beyond that.
Beyond, okay, we don't have a follow-up. Okay.
I don't have that. Yeah, she lived in another city. It was 5 or 10 years or something, not very long. But no, she was 85, man. Okay.
This is the gap which I wanted to show you. Look at the size of this gap. Here is the knee which I started with. And I'm sorry, I'm not very good about this, but this is the gap, and you can see with the FLIR how big that is, deep. And then here's what I have done: reconstructed it with a piece of bone, and I use most of the time patient's host bone. The femoral condyles are very good. Sometimes I will use the tibial condyle and then fix it, but it has to be rigidly fixed. And in one of the pictures, before you fix it, you must make some holes, which you see these small holes, and then I put some cancellous bone and then put the piece on and then go ahead and fix it with screws. And in the end, this is what I want to see: a balanced knee. And this is a posterior stabilized knee, and I'm not using any other constraint. But
sir, did you use a stem here?
No, I have not. I have not used a stem ever in a primary knee. Only time you use it. Only time you use the stem when the medial or lateral collateral ligament is really gone, and then I will use a constrained knee. Otherwise, I do not use it. If I'm going to use a LCCK type, or I'm going to use a constrained knee, then I will use the stem. In all other cases, this PS retaining works very well for me.
All right,
and I'm sorry, but I am not very good with this thing. Otherwise, I would have shown you some more pictures. Let me see if I can get some more pictures, and then I'll show you the follow-up in which this bone is completely fused with the patient's host bone, and you can't even find the difference between the two.
So meanwhile, David, what would be your indication for using the stem in your case you showed? Khalid Sahab has shown a very similar case. He managed without a stem in a primary knee.
Yeah, it just depends on what you have at the time. We were doing a bilateral knee. I couldn't afford to have two knees fail on me. I mean, suddenly she was the mother of two physicians. That would be the end of it, I think. So if you want it to be more secure, certainly using a stem is very useful because, in patients that are osteoporotic or osteopenic, there's a good chance that if you just use the tray by itself without any significant amount of stemming, that there will be a stress failure and that it will just be a fracture really. That's what's happened in a few of my patients, not many, but it's been the major post-operative complication of any one of these total knees have done in recent times. We don't get a lot of infections. We don't get a lot of like poly failures or anything like that. In fact, post-operative pain and patella clunk seems to be much less with the cruciate retained design. I'm only comparing certain designs. I use the PFC routinely, and as I said just now, the post on the PFC is very big, and so therefore the corresponding cam is also huge, and so there's a big hole in which the patella engages. That can cause pain, right? So if you go to a more posteriorly located cam and post or some kind of cruciate retained device, then the likelihood you're going to get pain is much less.
So David, you would always use a stem in such cases? With advanced varus arthritis, for example, like the one you showed?
I tell you, the problem is I'm in the same situation as you. Many of the patients are not insured, and cost is important to them. You add a stem that you're adding like about $300-400 to the cost of the implant. So yeah, we try not to use them if we can, but then we stand the risk of going the other way. If they have a periprosthetic fracture, it will cost them even more. So yeah, I don't use a lot of stems. I generally tend to use stems on revisions, and that's because the bone loss is so bad that there's really nothing much you can do. And even then, I don't use stems. I use metaphyseal sleeves. They're fantastic, really, really good. So they give much more stability than some kind of stem. Yeah.
So Khalid Saab, when do you mobilize them without when you are not using a stem? How soon do you mobilize them?
Within 24 hours. First 24 hours patient is under epidural, so I do not let them stand up. But the next day, all of them stand up. On an average, one total knee, single total knee done will go home on fourth or fifth day post-op, and both will be seventh or eighth day. And they are mobilized, and they must bend to 90 degrees, be able to walk 40 to 50 steps, and go to the bathroom, come back and lay down in bed on their own with the help of a walker. Otherwise, I don't let them go. And I can tell you that 95 to 97% of my patients go within this time period, which I have told you. Some people, because of the comorbids or other problems, will take a little bit longer. Let me show you another case, if I can.
Please, go ahead.
Give me a minute.
So on the same line, Khalid Saab, how long do you brace them?
I do not brace. Initially, I may use the knee mobilizer to give the patient a little bit more sense of security. As in this particular case, this one is, look at this knee. And
Yeah,
then
the
this
left
is,
one.
Yeah, left one. And this is how I reconstructed it after look at this. And here is a picture of the piece which I'm taking out, and you can see how much part is missing. And then I've put in this piece, as you can see, with the two screws, and the same technique which I used, and it is his own bone, and it is fixed rigidly. And in the end, this is the post-op picture, immediate post-op. You can see the two screws holding it together. This is the that was another patient. This is the patient which you saw the X-ray in the pictures. Now you can see the way the knee is. But the main thing is, in my opinion, whichever system you use, whichever total knee you use, they all give you very good results as long as you've done the soft tissue balancing properly and you have a stable implant in there. You can see all the results. They are within very little margin of improvement from one to another. all these registries show you the same thing. You know, something is 2% better, something is 1% better. And in the end, I think it mainly means what has been, how much it has been taken care of and how good the surgeon has done the job according to the specifications and how much stability and alignment you got it on the table. If you do not get the proper alignment, fixation, stability on the table, you're not going to get it afterwards with a brace. The stresses on the knee are very high, and the only way to do that is make sure that the knee is perfectly balanced in flexion and extension. Your medial and lateral collateral ligament are stable no matter what you do. I do not usually have the stems available, but sometimes I have had available, but so far I can tell you that I have not used it in a primary knee. I have not used a stem in a primary knee, except for one case where I did from the very beginning. It was a total congenital dislocation of the knee, and I was replacing his knee. There I used a constraint, primarily a constraint joint, because their ligaments, I'm sure you know what kind of picture that was.
Khalid Saab, your choices of bone graft versus using metal wedges, tantalum wedges.
Yes, tantalum wedges, again, Dr. Choon really pointed out the real thing, and that was cost. How much is the cost of a tantalum one wedge, and how much is the size of that wedge? And then you are using, if you're using the cones, how much is the cost of that cone? I have, for the last 30 years, in the knees, only in the revision, I have used these things, where the patient is mentally prepared that the cost is going to be sky high, because on one particular revision, I remember, because of the laxity and the way the bone was destroyed, I ended up using the implant, and the total cost just of the implant to the patient was about 16 lakh rupees, because of all these other things, stem and the sleeve and the femur sleeve and the tibia. And you know, if we start doing that, how many knees are we are going to do in this country?
Exactly.
So these, Dr. Khalid Aslam, sir, I just want to, yes, they are very extreme cases which you are showing, I think. And the knee over here, we can see that almost the medial tibial condyle is absent. Do you have the post-op X-ray of this left side, sir?
I'm sorry, it is, let's see, no, that's the right one. No, I don't have right now, but if you'll send me your email, I'll be happy to send them.
Yeah, because obviously if these are very, very extreme cases, and normally we are using stems and wedges in these kind of cases, and sometimes even tibial sleeve I would prefer to use. But if you are getting away with a bone graft, I think that really worth publishing. Your result will be worth publishing and sharing, because obviously by that we can really save a lot of cost for the patients.
I have been doing them, and I have shared it in the meetings, in other meetings where I've been invited to give talks, and I've shown this, and I've shown the same technique which I'm showing you here, and I've had very good results. Thank God so far. In all these reconstructions, I've had one infection, and I must have done about 30, 40 of them, maybe 50. These extreme cases I'm talking about, not the minimal, small little bone piece or something like that. And all the other cases, I've not had a single failure. I have even, we talked about that rollback. I have taken pictures of my patients sitting in prayers, because a lot of my patients can sit down for prayers. And I have taken their picture in prayer and with a complete squatting position. And there is no dislocation or subluxation as people claim that it might happen. And of all these people I've done, I don't remember anybody coming back for a revision because of loosening or anything else.
Yeah. So that brings us to another important point of discussion. David, how many of your patients are able to squat? I believe that is the same culture in your part of the world. People requiring socially to squat?
Actually, our culture is different from yours. We have jazz, and they don't go. The Muslim population doesn't have much need for knee joint replacement. I don't know why. In my hospital, the government hospital, we see equal proportions of Indian, Chinese, and Malay patients. The Malays are Muslim largely, and actually all the knee replacements go to Chinese women because they're the most bow-legged of the lot, and the Malays just have straighter legs, I guess. So very few just get done. And so here's the thing.
It was a generic question. I mean, would you allow them to squat?
Yeah, no problem. But so when I talk to Indian surgeons, and I say, why is it that a large proportion of your patients, just like Pakistani, they can squat after the surgery? Well, before the surgery, they could squat anyway, despite the terrible deformities in their knees. They could actually sit cross-legged, right? Because they had to because they had to go to mosque, etc., etc., etc. They would just bear with it. But our patients don't have to go to mosque. So in fact, preoperatively, many of these patients have a range of motion of, maybe 10, 15 degrees of flexion contracture to about 100 degrees of flexion. That's it. They can't do more than that. And actually, if you follow them over a long period of time, 3 years, I don't do it regularly, but if they do come back, actually they have full range of motion and they can squat. But if you ask them how often do you squat in a day, they say, well, I don't. I just squat maybe once a week or something, once a month. So really, the need to.
I'm sorry, but I have to add here. Probably Dr. David Choon don't know this thing, but our patients are praying 5 times a day, and they're sitting down 5 times a day.
No, I'm aware of that. That's exactly why your patients can squat so well after the surgery, because
I think some of it
is determined by preoperative range of motion.
Yeah, no, so we have these severe contractures, and I've had patients who cried after this. They were able to sit down and prostrate properly because they told me that they have not been able to prostrate for 15 years before that. And then when I encouraged them and I showed them that you can go ahead and do it, and gradually they've done it. The important part which I have learned is that in the first 3 months, if they, with pain, they keep on doing gradual exercises, they can squat and they can sit down prostrate for prayers. But if they don't do it in the first 3 months, then it becomes very difficult for them. Some can do it later on, but most of the time, the scar is mature and they cannot do it at that time.
Another dimension to this discussion is obesity. So I want to ask the panel, how would it change the choice of your implant in kind of big obese patients? Would it change with you, David?
No.
Khalid Saab, very obese patient, BMI of more than 30, even 40?
I have done the biggest person here in Pakistan I've done was 135 kg. And I used the posterior stabilized knee, and she has done well. Now, of course, her flexion is only 125 degrees, but because her flesh or fat or whatever you want to call it does not let her knee go any further than that. But she's pain-free, she's walking, but she says that I cannot bring my weight down. Although I had told her that increased weight leads to early loosening and problems, but she says, doctor, I can't do anything. What can I tell her? We can only explain to her. We cannot really make her do anything.
Dr. Masood, can I ask something, please?
Please.
Yeah, I just want to ask Professor Choon about what is post-operative infection, and also what is DVT prophylaxis? Does he give any prophylaxis or not?
Post-operative infection, I'll get one infection in 3 or 4 or 5 or 6 years, something like that. Not a lot. It's like maybe 1 in 1,000. That's my post-op infection rate. And usually it's in some patient who's either immune suppressed or had previous injections into the knee or had some trauma or something like that. Generally, it doesn't arise in fit patients and it doesn't arrive in no. So that's the first thing. Yeah. And what was the other question? Infection and
DVT prophylaxis.
DVT prophylaxis. Well, okay. Well, I tell my patients that DVT prophylaxis is early mobilization and a spinal epidural. And I say, look, if I give you some kind of anticoagulant, then there's a risk that you'll bleed. And if you bleed, then there's a risk you'll get an infection from that. You won't get a DVT, but you get an infection. Okay. And there are lots of studies to show that prophylaxis makes no difference to the PE death rate at all, even in the West.
As a matter of fact,
आप क्या देते हैं सर? DVT के लिए?
I do not really give them anything for DVT prophylaxis, early mobilization. And as a matter of fact, if you will look at the latest recommendations from College of Pulmonary Physicians in America, they are saying now use aspirin and a mechanical device while they're in the hospital. Naturally, nobody takes the mechanical device home. And
you don't even give them aspirin?
Yes, I don't stop aspirin. I do not stop aspirin. Those people who are on aspirin, they're not given on the day of surgery, but from next day onwards, they are on aspirin.
I think I have no problem with aspirin, but the problem is my anesthetist has a problem with aspirin. He says, there's been some record that in the past, if you do a spinal epidural and the patient's on aspirin, you increase the risk of a spinal epidural bleed.
My patient has a problem with the other one, not with aspirin. He say my anesthesiologist say aspirin is fine, but if you have to give what is that?
Clopidogrel.
Then he says no. Then he says no. I will not give.
That has a much longer half-life.
Yeah, so we stopped that 3 days before surgery. But all other things, and the clopidogrel started the very next day of surgery. The first post-op day in the morning, they get their dose.
Coming back to the same topic, infection. Sir, go ahead.
As far as infection is concerned, I'm not that lucky as Dr. Choon is. I have done about 1,700 days in the last 10 years in this hospital where I'm working now, and I've had 8 infections. So I don't know what is the rate or whatever it is, but those are my infections. I've treated a lot of them, but they came from other places.
0.4%, sir. Takriban.
Dr. Masood, what is your practice for DVT prophylaxis?
Well, we are compelled by the hospital policy, which states you have to give anticoagulation. We are giving low molecular weight heparin for about a week until they are fully mobilized to all arthroplasty patients.
Masood,
unless there is a yes, please, Mansoor.
Yeah, our experience has been that we used to give low molecular weight heparin, but it led to a lot of hematomas. I don't know, our population is very sensitive to enoxaparin. Then we shifted to the factor 10A inhibitor. And initially our experience was good, but again, we had the same problem that about 20 to 30% of them had post-op hematomas. Now we are on aspirin, and even that we have to stop in some patients if we see the knee looks very boggy by about the 4th, 5th day. But so far, in 13 years of joint replacement, we have had 2 documented DVTs after joint replacements, either hip or knee. And we did a study which was basically on hip fractures, looking at DVT post hip fractures, and our incidence over about 1,500 fractures was about under 1%. I think it was 0.8% or something. So maybe that's the Pakistani average.
I can tell you that I have looked at all my patients. I've had one DVT, but that was 6 weeks afterwards. The gentleman was a Sardar or Nawab, whatever you want to call him. And when he went home, back to his village where he came and stayed here for 6 weeks. Then he went back home, and there he was treated like a king and kept in bed. So he came back with a swollen leg, and that's the only one I know. But I really don't think that is a surgical fault or anything. It is just that the person himself asked for it.
So,
Asians are superior people to the West. The Van Leiden factor is not present at all in our population. So the only two things that predispose our patients to some kind of DVT is protein C and protein S deficiency, and that's it. And the incidence of that is not very high.
Exactly, exactly. But what we follow Western literature, so we are kind of compelled. But I
No, but
agree that's
even in
the
the
ground reality.
no, but even in the Western literature, they talk when they are not talking about any more low molecular heparin or anything else. I just told you the this is the official statement. You can go on the internet and get it from the College of Pulmonary Physicians, which I told you that aspirin and a mechanical support. Now, mechanical support, you know what happens in Pakistan. You don't want to keep on reusing it, and if you keep using the disposable cuffs, that adds cost how much? Again, our patients, at least in my hospital, 70 to 80% of my patients are paying from their pocket. And when you increase the cost, they start running away.
Okay, before we conclude, one last point of discussion was a younger patient of around 50, 55 years, male or female, in which we are compelled to do the knee replacement because of advanced arthritis. So beginning from Mansoor, what would be your choice of implant?
Well, if I'm having to deal with a young patient with osteoarthritis, have to give a little bit of a background scenario of my institution because it's a free hospital. We use a variety of implants. Some of them, like I will have to take the name, for example, the U2 is a Chinese implant. Some we have which we use like Zimmer. We use the medial pivot also. I'm personally a fan of the medial pivot, as I believe you are too, and you made a good presentation on that. And for that, somehow I will feel that the medial pivot will give a better, longer result as compared to a standard like cruciate retaining knee. However, if a medial pivot is not available, a posterior stabilized will be a very, very close second choice for me.
All right, David, your choice?
Well, I tell you, you will be surprised at what I'm going to say. If that person is young and has got good bone stock, I'd use the cruciate retaining implant, obviously, because that's what I do. But I'd use an all poly tray because that's the one that's going to give you the best long-term result.
Exactly.
I mean, even British registry, somebody presented it just I can't remember. It shows the best results, really.
I think Dr. Nasir mentioned that in his presentation. The best results were still with the monoblock, all poly, non-modular tibial component. Right? That's right, Dr. Nasir?
Yeah, my choice would be PS type of implant, and I would prefer PFC Sigma because I have been trained with PS, and I personally believe that you do what you are best at. So, because I'm not routinely doing, I think it has been years that I have done CR knee. So, I would do a PS type of PFC Sigma knee.
So you won't do a mobile bearing there?
There's already a lot of literature on that, I think, and we are not in a I mean, we don't have an uncemented implant and we are not doing it, so I don't think that mobile bearing is in fashion anymore.
Khalid sahab, aapki choice?
मेरी choice ये कि I think I have tried all these implants, but I still think in my hands, best one is the posterior stabilized knee, and I use it on all my patients. And I have done it on ladies who are 45, 50 years old, and now I have 10, 15 years follow-up, and they are doing all right.
Khalid sahab, in your own personal training, you must have used monoblock tibial all poly component. How was your experience with that? And would you make it a choice now also?
No, I actually, in my training, when we were initially, that's all what was available. There was no metal backed one. And at that time, the biggest problem with this thing was that there was early loosening. Maybe it was a cementing technique, maybe it was something else. But that was causing a very early loosening and ended up revising it. So metal back was the one which started, and then we had those non-cemented ones. And I am now fixed on metal back, and I feel very comfortable doing it. And so far, my revision rate is in I don't know. Again, maybe there are some patients who went somewhere else to get revision done. My revision rate is still very low.
So David, how's your experience with all poly and how frequently you do them? All poly tibia.
I went through a phase where almost every total knee was an all poly. Yeah, about 500-600. Yeah, something like that. It's not the hugest number, okay? Because it's just something that I decided to do maybe about 2-3 years ago. But I've been very encouraged with the results. Patients are happy.
Right.
Why
Yeah,
it is not
the
so
Cost is good. Cost is low.
Cost is low. Exactly. That's
Yeah.
the major point for our countries. It certainly reduces the cost. And the overall results, long-term results have been there. I have gone through the literature, very satisfying also in terms
If
of
you guys invite me
outcomes.
back again, I'll
I
give you another talk about why it works so well. There's a lot of evidence.
Yeah, we'll have more talks soon.
Let me just
Sure.
add one thing here. I have seen there are people who are doing this monoblock all poly, and I have seen them, but maybe the successful ones, naturally, they did not come to me. But the one which I have seen, they have had very early loosening. So I don't know what was the reason. I did not look into that, but I saw the problems. So I decided to stay away from that and then keep on doing what I think what is working best in my hand.
So I think we are already overshooting our time. Malik Saab, any last comment you were about to make? Malik Javed Iqbal Saab? No, I think no. So I think we got Shams Bhai. Yes, sir, please.
I just want to say hello to Khalid Aslam Saab. That's all.
Your neighbor. You should say it more frequently, sir. He's your neighbor. Shams Bhai.
No, I'm in isolation, total isolation for 7 months, 18 days and 10 hours.
All right. Okay, guys. Thank you very much, faculty, all the faculty
you very
members,
much.
participants who have
Thank
held
you,
on with
Masood.
us.
Thank
Yeah,
you.
yeah, exactly.
And I
So,
promise next time, let me just add one thing here. Next time I'll have a better presentation than what I did today, because unfortunately, for some reason, I thought this was not today, but next Saturday.
no issues, sir. No
and I was
issues.
not
We'll
prepared.
engage you again.
Yeah.
No problem.
I said,
No problem.
My mistake. I accept it, and I just apologize.
No
for
problem.
it,
Not at
because
all.
it's not,
Thank you,
good.
David, for taking your time out overseas. You've always been very resourceful, very helpful. Thank you, Nasir Saab,
Thank you.
Mansoor,
Thank you.
everybody, all the audience participants. I hope it was useful. And inshallah, we'll meet again. Thank you and Khuda
Thank you.
Hafiz. Assalamu alaikum.
Khuda Hafiz.
Yeah.